This is our monthly community forum for the Wisdom Study. Usually these meetings occur the last Monday of every month, but due to the Memorial Day holiday this month, we've moved it a week early. So thanks everyone for joining. If you haven't yet, please introduce yourself in the chat. We'd love to know who's here and also what brought you to the forum, maybe where you're from. We've got a great discussion today. We have Mara Schunberg who's joining us. This is actually a topic we meant to discuss last summer and had to cancel and postpone. So we're excited to have Mara on today. We also have a couple of our other investigators who are on today, and we'll touch base a little bit about some of the breast screening guidelines that you may have seen in the news as changing, or their drafts for it to change. And actually Mara's work goes hand in hand with that discussion as she's focused on improving the quality and outcomes of older women and their decision-making around breast cancer screening. So excited to have Mara join us today. So again, if you please can introduce yourself in the chat, what brought you here? We'd love to see who is here. Just some logistics as well. So, we do want to hear from you. The whole goal of these forums is to hear from our audience, to hear the questions that you have, so that we understand, where things are unclear, where we can provide more information, and also to have a discussion on the topics that mean the most to everyone who's joined and the most to the community. So you can add your questions to the chat. You can raise your hand. If we're having a Q&A, feel free to unmute and ask your questions live. We do ask if you're not speaking to please mute yourself so we can give full audio attention to the speaker. You'll see that the meeting is being recorded, and we always post these to our website and also to our YouTube channel so that if anyone misses them, you can see them later. And we do have a short feedback survey that we'll ask people to complete at the end. So our mission in these community forums really is to move together toward equity and better outcomes in breast cancer for everyone, and really wanting to make sure that we discuss topics around women's health, topics in breast cancer and breast cancer screening. It's a big topic area. There's a lot of components that goes into this, and really want to make sure we have the ability to hear from our community, to be able to present and talk through some of the latest information that may be out there that you may have heard in the news, and be able to have a discussion and answer some of those questions. So we know that breast cancer is still an ongoing issue. 40,000 women a year are still dying of breast cancer. We know now that it's not one disease, though, some can be very aggressive. Some are also very slow growing. We know that younger women are at risk for those most aggressive cancers. Most often people think about family history as being the main risk factor for breast cancer. And we know, though, that there are lots of other components that go in and lots of other ways that we can evaluate someone's risk. Family history is only one piece of the puzzle. One of the main findings that we've seen so far in the Wisdom Study is that 60% of women that we have found to have a genetic mutation in one of the 9 breast cancer genes, 60% did not have a first-degree family member with breast cancer. And so we know that those are the people who have a family history are the only ones who are offered genetic testing in clinical care. And we know there's many more people out there who may be affected. And our goal really is to try and identify those at highest risk and be able to intervene and help to improve outcomes, both in screening and prevention. We also know that breast cancer outcomes are worse for certain communities, and trying to figure out why that may be. What are some of the structural reasons, some of the biological reasons? So really working together to try and improve outcomes for all women. Just to add, so you may have seen in the news in the last couple of weeks that there are some new guidelines that are being proposed by the United States Preventative Services Task Force, the USPSTF. It's a mouthful. The last guidelines you can see that were issued gave an age to start screening at the age of 50, with those between the ages of 40 and 49 to have that be an individual decision as to whether they would start screening. Age to stop, 74, and the frequency every other year. And so 2 weeks ago, the USPSTF issued a new set of draft guidelines that changed that age to start screening down to 40, keeping this age to stop screening at 74, and then to screen every other year or biennial screening. And so there's been a lot of discussion, a lot of interviews and things you may have heard in the news about how this may affect screening and things like that. And so our wisdom team and our team of investigators and clinicians and doctors are reviewing these guidelines right now. There's a lot of sort of background work that went into evaluating the data to see if the recommendation should change. And so our team is reviewing those currently. This is a little bit busy, but just to say that, you know, these recommendations that just came out are still just based on age. And you'll know from wisdom is that we're looking to test a much more comprehensive and personalized approach, wherein there are more than just age as a risk factor in determining whether someone should start screening and how often. So again, age is just one piece of the puzzle, and we really are looking at a more comprehensive risk assessment in the wisdom study, and giving that comprehensive risk assessment at the start and ongoing throughout the years of participating in wisdom so that we know how someone's risk may change over time. So right now, as we're all reviewing this evidence and looking at the data and the recommendations, we aren't changing any of our screening recommendations in wisdom right now. If we do decide that that's a change that will need to be made, we will definitely reach out to everyone in the study. But at this point, this is still under evaluation and really under review. And we will let you know and have a more detailed discussion on this in the future. I will say that the one thing the revised guidelines do call for is more research and more information to help inform the guidelines in the future. And that is exactly why we're doing the wisdom study. We are trying to generate that new data and that new evidence, combining all of the risk factors together. And so that call for more research from the USPSTF speaks directly to the wisdom study. In fact, before they came out with their guidelines, they asked us if our data was ready so they could include it in their evaluation. And unfortunately, our data is not quite ready yet. But we are, you know, really looking forward to when we'll be able to share our outcomes to inform those guidelines and really be able to make a meaningful change. So just to say, we are so incredibly grateful for our wisdom community and for our wisdom participants for being part of the solution, for being part of the evidence generation, and just know that all the work that we're doing together will make an impact and we'll be able to improve screening and improve outcomes for all women. So just a big thank you to everyone for being part of these conversations, being part of the wisdom community and being part of the study. And we will do a more focused discussion on this topic, you know, what we've learned, how we've looked at the data that is part of the guidelines. There's a lot of information that we want to share, and we'll be able to do so after we've done our review as well. Some of this Dr. Schoenberg will go over in her presentation as well, but just wanted to call that out from the beginning. More information to come, and a big thank you to everyone for being part of our work to make bigger changes in the future. So as I mentioned, this month we will discuss breast cancer screening in older women. We've had a whole host of other topics in the past. These can all be found on our YouTube channel, linked through our website. We are always asking this group for new suggestions on other topics to discuss. Last month, we talked about breast cancer and environmental exposures and how to measure those. That was a very popular one. We'll continue that discussion in the future with more topics on or more discussion on that topic as well. So please do let us know what you want to hear about, and we will bring in a team and bring in some of our advocates to help discuss that as well. So without further ado, I will introduce Mara Schunberg, who is at Dana-Farber in the Harvard Cancer Center. So as I mentioned, her research focuses on improving the quality and outcomes of older women's decision-making around screening for breast cancer. So she's developed some decision tools that can help both patients and providers make decisions around screening that are, impacted by someone's life expectancy and lots of factors that go into a decision around when someone should stop screening. So I will stop sharing and let Mara share her screen. And again, if you have any questions, please add those to the chat. We'll pause. Mara, I might pause you at certain points if there are questions that come up so that we can ask those throughout the presentation.
Absolutely.
Yeah.
Let's see here. Are you guys seeing the right view? Is it look good, or do I need to?
I see the presenter view. Let's see.
Let's see here.
Yeah, usually go to display settings and switch screens.
Okay, now you guys see it, right? Does it look good to you?
It looks the same to me.
Do you see mine?
It still has the like note view, next slide view.
And what about now? Let's see here does that work?
I am not seeing anything.
Okay. That work?
Yes, there we go.
Okay.
Great.
Thank you so much. Thank you, Allison, for the introduction. And I'm sorry I did have to cancel in the summer. My daughter had a acute health issue. She's doing much better now. So much better time to do this talk. And I guess it all worked out since breast cancer screening is a hot topic right now. So let's see here. Well, I wanted to advance. Now I want to advance. Maybe I'll end up having, oh, good. Okay. So I thought I'd begin with a story of my grandma. So at 78, my grandma went for a mammogram, and I was like, why'd grandma go for a mammogram? She already had been diagnosed with COPD, and just on those two pieces of data, a 78-year-old female with COPD, her life expectancy would be about 10 years at best. And my family's like, oh, because her doctor told her. And sure enough, she was diagnosed with a stage 1 ER positive, HER2 negative, or low risk breast cancer. So then she had to undergo a lot of treatment decision making, and we talked about it because she knew I was interested in this topic, and she decided to have breast conserving surgery, not have a mastectomy. I knew from at that time that radiation therapy could lower your chance of the breast cancer coming back in the breast, but wouldn't likely help her survival. And with that information, she decided to forego radiation therapy, but she was started on aromatase inhibitors, which is a type of endocrine therapy to lower her risk of recurrence. But it made she had osteoporosis, and it made her have a lot of bony pain, and she just didn't like how she felt on it. So they switched her to tamoxifen. And again, she didn't like how she felt on it. So at 3 years, she stopped taking it. Then at 6 years, she had a local recurrence. She didn't even tell anyone, but the doctors did pick it up. And at that point, they recommended mastectomy, but she didn't want it. And so she underwent lumpectomy again. And then at 10 years, right before she died of her COPD, she's like, Mara, how come I had that mammogram? And, in my grandmother's life, it's not really clear that mammogram helped her live longer or better. Yes, she would have had a breast cancer, but would it have caused her any trouble? It's not clear to me. So it's really important that we include women, especially when we don't know if there's benefits or harms to screening, particularly in women age 75 and older in the decision making. So I just wanted to share that story. So what do the guidelines recommend? Allison just went over the USPSTF guidelines pretty clearly. but they've just been expanded to include mammograms every other year for women ages 40 to 74. And they state again that the evidence is insufficient for women age 75 and older. However, they have other guidelines that say for any guideline where there's insufficient evidence, they recommend that clinicians should be prepared to discuss the service if a patient asks about it. The American Cancer Society recommends annual mammograms for women ages 45 to 54 and recommends mammograms every other year for women age 55 and older, as long as they have more than 10-year life expectancy. And they do strongly encourage shared decision-making for women age 75 and older. The American College of Obstetrics and Gynecology recommends mammograms to offer mammograms for women ages 40 to 49 in the context of shared decision making. They recommend mammograms every 1 to 2 years for women ages 50 to 74, and they too recommend that women 75 and older engage in shared decision making. The American College of Physicians actually does not recommend mammograms for women age 75 and older, nor for any woman regardless of their age with less than 10-year life expectancy. But the American College of Radiology recommends mammograms every year beginning at 40 and to continue until a woman has less than 5 to 7-year life expectancy. So while there's variation in the guidelines, there are some themes. Most of the guidelines encourage shared decision-making, particularly for women age 75 and older, and they recommend not screening women with short life expectancy, generally defined as less than 10-year life expectancy. To get a good sense of how good we are at screening older women by life expectancy, I've done a few studies looking at screening in older women in the US by their life expectancy. This is data from the 2019 National Health Interview Survey. It's a population-based survey of older women or of adults age 18 and older. We focused on women age 65 and older, and we found that 67% reported being screened in the last 2 years, including 78% of those with greater than 10-year life expectancy and 43% of those with less than 10-year life expectancy. And we will look at women age 75 and older, 51% of those reported being screened in the last 2 years, including 38% of those with less than 10-year life expectancy. And we thought that was still quite high. And it's important to note that the 2019 data are the most recent data since before the pandemic. And while screening did drop during the pandemic due to obvious reasons, most data are suggesting they're approaching pre-pandemic levels. So these data probably give us a best sense of what's going on now.
Maura, just a quick question, and then I might have you just slow down a little bit because it's a little fast. So just to clarify, so this is saying that if we're looking at 70 women who are 75 and older, overall about 51% of women are screening every 2 years. And then if you break that down by women who have a longer life expectancy, so more than 10 years, about 67% of those women who have a higher life expectancy or longer life expectancy are screening, versus those who have a shorter life expectancy are screening at 38%, so not quite as much.
Yeah, and actually, and this is a paper that's under review, but we're actually showing, as opposed to colon cancer screening and prostate cancer screening, we're actually seeing some appropriate movement in the right direction for life expectancy, where those with higher life expectancies are more likely to be screened and moving in that direction, and those with shorter life expectancies are less likely. But still 38% of those 75 and older with less than 10-year life expectancy is quite high. And we think we could probably get it more targeted based on the likelihood of benefiting.
Okay. And then there's a question in the chat, how do you define your own specific life expectancy? But I think you'll get there. So
I will get there. So I'm going to hold, and then I'll answer that one at the end if I didn't do it good enough. Any other question before I move on?
Nope. I would just say slow a little so we can.
Okay. I do talk fast. So yeah,
that's okay.
So to try to understand better older women's screening decisions, now many years ago, showing you how long I've studied this issue, I did a qualitative study where I interviewed women aged 80 and older and clinicians who care for these women to try to better understand what factors influence older women's screening decisions, to try to better understand why so many older women with little chance of benefit were being screened. And I found that there were 4 main groups of factors that influence older women's screening decisions. Patient factors, their habit, they'd always been screened, why would they stop now? Their perceived risk, maybe they had a breast biopsy in the past, maybe they had a family history of breast cancer that made them feel that they were at higher risk. Their previous experiences, which could influence them to be screened or not be screened, depending on how they went. The need for reassurance, it can be reassuring to have a negative mammogram. Very few women mentioned their age, health, or function affecting their decision-making, however. Others were influenced by system factors. It's very easy to get a mammogram. Why wouldn't they go? Some simply received a mailed reminder card that it was time for their annual mammogram, and so really no decision-making was involved. Others were influenced by social influences. Maybe their daughter felt strongly that they be screened. Maybe they saw a family member or friend have breast cancer, and that could actually influence them to be screened or not be screened, depending on what they saw. But probably the strongest factor that influenced older women's screening decisions were their physicians' influence. And again, we had interviewed physicians as well. And physicians, much more so than patients, were likely to mention the patient's age, the health of the patient, their function, and the patient's life expectancy, influencing their screening recommendations. But they did say that talking to patients about their life expectancy required a strong doctor-patient relationship, that talking to patients about stopping screening took time during already very busy primary care visits. You could simply treat older women with endocrine therapy, a pill. So why wouldn't you screen these women? Also, there was variation in the guidelines, and they felt that more data was needed. So since this time, me and many others have tried to get more data on the benefits and harms of screening older women. Say Lee at UCSF did a meta-analysis of 5 of the 9 randomized control trials of mammography screening. So randomized control trials are the highest quality data, and there are 9 or 8, depending on how you count them, different randomized control trials, but only 5 of them included women 50 to 74. And he used the data from these trials to see how long it took for 1 out of 1,000 women to avoid breast cancer death as a result of being screened. And he found that on average, 10.7 years passed before 1 death from breast cancer was prevented for 1,000 women screened. So this is where that concept of needing at least a 10-year life expectancy to have even a minimal chance of benefiting from screening comes from. Others have looked at false positives tests. Deanna Brathwaite did a study of breast cancer surveillance consortium data, and she looked at how often women ages 66 to 74, if they were screened every year for 10 years, 48% would experience a false positive at least some point. If they were screened every year or every other year for 10 years, so like 5 mammograms, 29% would experience a false alarm. And these can be, anxiety provoking, and numbers were similar for women ages 75 to 89. I did a
And
study.
Mara, can you define a false positive for us too?
Yeah, so that's when you go for a mammogram and your test is abnormal, and it requires additional tests to make sure you don't have breast cancer or to diagnose breast cancer, but it wouldn't be false. But so if it's additional tests do not show breast cancer, then we consider that a false positive test. You had to go through another mammogram, you had to go get an ultrasound, you had to get a breast biopsy, and it can be very stressful. I'll show you in the next slide. So we would consider that a false alarm. Sometimes that's an easier concept. So I did a study, maybe as you get older, having a false positive test isn't that big a deal. Maybe it's not that stressful. So I recruited 164 women aged 65 and older at the time of their breast biopsy. They're waiting in the waiting room, wherever, to try to go and get their breast biopsy. And ultimately, of those women, 94 were not diagnosed with breast cancer. So of those 94 women, we found at the time of that breast biopsy, they're waiting, they don't know anything, they just know they have an abnormal mammogram. 76% reported some negative psychological consequence. Maybe they weren't sleeping well, maybe they didn't feel like talking to friends or family. They reported some kind of anxiety component. And still 39% reported this type of anxiety or some kind of symptom at 6 months. So maybe not so benign. And then the hardest concept and the biggest potential risk factor or harm of screening is overdiagnosis, or finding a breast cancer that otherwise wouldn't have become a problem in that woman's lifetime. Maybe even in my grandma, we could wonder if that was a case of overdiagnosis. Unfortunately, like my grandma, you never know if that breast cancer is going to be one that grows and is going to lead to a woman's demise, or if it's one that isn't going to cause problems. And I thought this is a good graphic to try to understand the concept. So in scenario 1, Maria goes for her mammogram, her breast cancer is found, she undergoes treatment, and then she lives to 85 and dies of her heart disease. In scenario 2, she never goes for that mammogram. Her breast cancer is there, but it's never found. And she still, at 85, dies of heart disease. So in this case, Maria's breast cancer is overdiagnosis. Again, it's hard to know at the time of diagnosis, though, if that's an overdiagnosed case or not. So putting these and other data together, Louise Walter at UCSF and I did a systematic review of all the data that was available on the benefits and harms of screening older women. And we found that on average, 1 to 2 fewer breast cancer deaths per 1,000 women aged 70 to 79 screened over 10 years occurred. But again, there were harms to screening over 10 years. About 200 out of 1,000 women would experience a false positive test or false alarm. and 20 would experience a benign breast biopsy, which again can be stressful. 13 out of 1,000 would be overdiagnosed or had one of these breast cancers found that would be unlikely to otherwise have caused them any problems. And then they undergo treatment, and treatment itself can be harm and cause some side effects. And the 13 out of 1,000 was an estimated range of about 30% of the breast cancers found in these women we thought would be overdiagnosis based on the data available. So now that I had some data available, I wanted to think about how can older women make high quality breast cancer screening decisions. And I realized that these decisions required a consideration of their risk of breast cancer, their life expectancy, and their preferences and values. So in terms of life expectancy, getting to the question, I worked with colleagues at UCSF. I met Beth Israel, but we decided to join forces and make a website called ePrognosis. And you can go to ePrognosis and you can click on the calculator tab. And basically you can get to this index, which is actually two indices. I developed one with data from that National Health Interview Survey, and Lee developed one from data from what we call the Health and Retirement Study. And we had so many similar risk factors that combining together led to a 15-item index versus 11 or 12 if we had them separate. So we combine our indices together, and a patient or clinician can put in their patient's information on the patient's age, their sex, their BMI, their perceived health, whether they have COPD or had a history of cancer or congestive heart failure or diabetes, whether they smoked, their mobility, their function, and based on a patient's answers to these questions, they get a health score. And based on their health score, we can tell the patient their chances of dying in the next 10 or different time periods. So I'd put in my grandmother's risk factors, and she would have about, at the time when she went for her mammogram, her chance of death was about 52%. So she was in that, probably not going to benefit based on her life expectancy. We also have, additionally, if you go to the cancer screening tab on ePrognosis and you enter your life expectancy or health characteristics, it goes to a final screen that gives you a sense of whether you're more likely or less likely to experience benefit or harm from screening based on your life expectancy. So again, this is my grandma's information at the time of screening, and she was right on that line. So again, it's important to consider a patient's preferences and values. And while ePrognosis is a great tool, it's not a tool that can be read over time, and sometimes it's too high literacy for patients. So I wanted to develop a tool to help patients understand the pros and cons of screening so that they'd be better informed to talk to their doctors. So the next few slides are just pages of a decision aid, and it's not even all the pages, but I just wanted to give you a sense that I have created a decision aid on mammography screening for women ages 75 to actually even 75 and older. There's two ones, one for women 75 to 84 and another one for women age 85 and older. In the decision aid, we ask women the questions in my health index, and we tell them if they have very few health problems, a mammogram may help you live longer. And if you have many health problems, a mammogram is very unlikely to help you live longer. And in fact, experts generally do not recommend mammograms for women with many health problems. We go over some of the competing mortality risks, or that many more women age 75 and older die of heart disease than breast cancer. We go over some of the outcomes of screening, such as false alarms. We tell women that doctors are unsure that having mammograms will lower your chance of dying from breast cancer for women 75 and older, but some studies suggest the numbers below, or that one less woman out of 1,000 may die of breast cancer who chooses to have a mammogram. We go over some of the treatments for breast cancer because it doesn't make sense to screen someone if they don't want to undergo treatment. We ask women to rank how they feel about the pros and cons of screening just to see what matters most to them. And then we ask them where they are in their decision making, and we encourage them to talk to their doctor. And this tool is actually on ePrognosis. So we have a decision aid page on ePrognosis, and you can go and find this decision aid. We have it available in English and Spanish, and we have an even lower health literacy version, which takes out some of the figures, but is also even easier to read. But one of the things that wisdom is all about is incorporating risk into decision-making around breast cancer screening. So in terms of older women, I have current grants, so these aren't quite available right now, but I have a grant to develop a conversation aid on mammography screening for women aged 75 and older, a tool that a clinician would use with a patient during a visit. And it's going to incorporate a woman's risk. We're using the data from some of the modeling that informs the United States Preventative Services Task Force. So we're going to incorporate risk factors like breast density and breast biopsy and family history, as well as health and how level of comorbid disease burden and a patient's age and whether they've been screened in the past 2 years. And we'll be able to individualize outcomes based on these risk factors. And we're making it very adaptable so that a primary care doctor can, in fact, just put an age if they want to, if that's all they have time for. If they just want to show you your chance of dying from breast cancer, it's going to be very flexible. This is what we call a wireframe, but the website's actually is actively being produced, and we're going to test it soon. I also worked on this other model to try to, what we call a competing risk model that would predict breast cancer and chances of dying from other causes at the same time. And we're also, this one is for women age 55 and older, and it's going to give women their risk of breast cancer in 10 years, their risk of dying from breast cancer in their 10 years, and risk of dying from other causes in 10 years to help with decision making. This is also a work in progress. Anytime I give this talk, someone always asks me about what about women with a history of breast cancer? And I have a mentee at Dana-Farber. I'm actually at Beth Israel because I'm a primary care doctor, but I actually have a colleague who's an oncologist at Dana-Farber who's we're working together to try to develop a tool to help women who have a history of breast cancer decide whether or not to stop screening. Because based on her data, if you've had one of those low-risk breast cancers like my grandma, the chance of having a breast cancer, again, is actually pretty similar to women without breast cancer, because often the endocrine therapy will lower a woman's risk of having a breast cancer on the other breast and even the breast cancer recurring. So this is something we're also working on right now. I like to end these talks with a picture of my other grandma, just to show how important preference sensitive decision making is. So my other grandma lived to about just after, she was almost 101. And she, I think she stopped screening around 87, which I guess was probably appropriate in her case. But around 98, she did a stint in a nursing home, and some doctor decided to do a breast exam and found a lump. And he was pressuring her to get it examined and evaluated. And my grandma would have none of it, but she's like, but he tells me it'll help you with your risk information. I'm like, it will not help me. You do not need to evaluate this. And, and she died a couple of years later from a stroke. So finding all breast cancer doesn't always change outcomes. So we have to be thoughtful of what makes sense and what's the best care. And again, we need to consider risk and life expectancy and how a patient values finding out what is going on versus sometimes more information can be harmful. So thank you, and I can stop my share and then we can talk.
Mara, one question that I had, there were a couple of terms that you used that I just wanted to make sure everyone was clear. So comorbidity is one, and there was another one that you just used, competing mortality, I think. So just to kind of explain those in lay terms would be helpful.
I guess let me go back to the slides of the decisioning because I think it'll be easier. So comorbidities are just like your list of conditions that you have. So if we go to e-prognosis, one thing nice is when we're estimating people's chance of death, and again, when we go to financial planners, they're estimating our chance of death. Sometimes it's better because they're estimating our longest chance. Whereas in medical decision making, we're trying to get a more accurate sense so that we don't overdo care and we don't underdo care either. But comorbidities are just your health conditions like heart failure or diabetes or COPD or such. And it's nice to incorporate function in addition. So sometimes people have a lot of conditions, but they can go run a mile. And some people don't have any conditions, but they can't walk very far and they're what we consider somewhat frail. So both of these can affect an individual's longevity. And then competing mortality risk. So let me show that. So yeah, none of us know what's going to be our demise. And this is, this is not necessarily how I would talk to a patient, but one time I was showing a patient this slide and they're like, yeah, I'm going to die of my diabetes. So just to show that somebody was like, breast cancer probably wasn't their biggest concern. And here they're going for a test that we're not clear. We have no data. There's no randomized controlled trial data that it'll help a woman 75 and older live longer or better. So, and our chances of dying of heart disease are much greater than breast cancer, but sometimes people aren't exercising or doing all the things we can do to lower our chance of something much more likely to kill us than breast cancer. And it's not clear that getting a mammogram after age 75 is going to help us.
Thank you. And in your discussions with patients, when you do show these types of graphs or even the other visuals that you've shown, what types of questions do you get? Are there typical questions that people ask trying to interpret the charts or the data? Just wondering how people respond to some of the visuals.
Yeah, no, so I mean, talking to about life expectancy is definitely a taboo topic, which I would say is on the forefront and not something generally done. But in terms of talking to patients about stopping screening is probably done slightly more than talking to patients about their life expectancy. And generally, there are several approaches. For a doctor, we've learned that if a patient has a lot of health conditions and they're clearly not doing great from, it's not that hard and they feel comfortable being like, you have a lot of other things going on, I think we should transition away from mammograms. And that's pretty easy. Someone like my grandma, who it's more vague, those tend to be more challenging conversations, and they require often more data, like here's your chance of breast cancer, and we just don't, it takes a long time to have a chance of benefiting from mammogram, years. And we don't know, in your case, if having a mammogram will help you live longer or better. Meanwhile, there are some harms. And a lot of people don't know that there are harms to screening because we as doctors don't always share them or have the time to share them. And so then we explain that, there are false alarms. People can go and have these events and it can be stressful. And some people say there's randomized or there's meta-analyses of trials that have looked at the effect of false alarms. And maybe some people are very much like, I'm willing to take the stress and false alarm if I can avoid breast cancer, death, or dying. But still, some are like, no, I don't want to go through all that. And there's a chance of finding breast cancers that otherwise wouldn't have caused you problems. And a lot of times by the time you're age 75 and older, you've seen what we call like the cascade, that you've gone for some tests that lead you down these roads that don't help you live longer or better. And so you kind of have some understanding that maybe not all tests are best. And so, how do you feel about this? Are you someone who wants to know? And even if it goes through a bunch of tests that wouldn't have helped you, and sometimes the tests lead to treatments that can be difficult and have their own side effects. Even surgery can be hard depending on who you are and when, although most people do well. Radiation therapy can be very, tiring. So, and even making all these decisions, and even the endocrine therapy, my own grandma had the trouble with some of those therapies. So, sometimes it's not going to be helpful to learn all this information, and it's not the best use of healthcare. So, sometimes I'll just be like, well, here's a decision aid, and I'll print it from ePrognosis. And sometimes women are like, well, I want this mammogram, but not that, I'm going to stop after that. Or no, they're like, I want this mammogram. Okay. I feel better. I know, the pros and the cons, are making an informed decision. And sometimes that same woman who's like, yeah, my sister had breast cancer at 80. I want to get my mammogram. Okay, good. Well, now, we have a value-based decision. I feel, good that I've told you that the chances are very small benefit, but for you, it's beneficial. But then a year later, they've decided no. Like, so somehow having this conversation gets the wheels turning.
Mm-hmm. And for those who have questions, please feel free to ask them or add them to the chat. I have one more, which is that there are a couple tools that you said are in development. One sounds like is available. Can you clarify which, like if someone wanted to go access one of the tools now, are they able to? Are they able to look at it themselves or with their doctor?
ePrognosis, everything on ePrognosis. So this decision aid is available and you can print it out. But these two tools, this one's almost available where you're going to be able to just get risk information, but probably still a few more months. And then the other one, there were probably a year or two before they're widely available because we're still testing them. But ePrognosis is available if you just go to the website for ePrognosis.
And do you suggest that women go through it themselves or wait to go through it with their doctor, or is there a suggestion there?
And you definitely can go through it yourself. If you have questions, it's going to require doing it with your doctor. But there's no caveat to not try it on your own. Some people, again, feel more, we've done studies with patients about whether they want to know their long-term prognosis, and about half do and half don't. And the half that don't are like, obviously nobody knows the future, and this is ridiculous. Why are you going to estimate my future? Versus the other half are like, well, I'd like it for planning, should I get a dog even, those kind of things. So some just find it helpful for medical decision making to have a better sense.
I put the website in the chat too. Other questions for Mara, or any other questions for the group? I know we have a couple of our wisdom investigators on too. We sometimes get asked the question in wisdom, why are we only enrolling people through the age of 74? So if you recall back to Mara's slide about all of the existing guidelines that are out there, all of them stop right now at 74 or shared decision making. And because Wisdom is really testing existing guidelines, we ended at least initial enrollment at the age of 74, but there are many people who are now past that age who enrolled a few years ago. So anyway, I think as Mara, you pointed out, there's still evidence, there's still data that needs to be generated. Perhaps there's an opportunity for another trial to compare screening for women above the age of 74 to be able to inform the guidelines. And I believe, correct me if I'm wrong, but some of the evidence that the USPSTF reviewed this last round actually showed more strong evidence that perhaps women could continue to screen in their 70s. Is that accurate?
I would say it's not, sorry, but
Okay.
so the only new data, but the only new data was one, there was this, when you don't have randomized control trial data, or like when you're randomizing one group to another, sometimes we'll use data from like Medicare and try to make it look like a trial. So one study did it that way, and they showed benefit for women 70 to 74, but not for women 75 and older. But there's a lot of math hand waving that it's, and again, they showed no benefit. So that's one study. Then they did some modeling data where, again, you're extrapolating from the trials, but again, there's no trial data for women 75 and older. So it's very hard to know what to make of it. And this didn't start like at 75. It was just saying if you expanded the age range of screening in general, perhaps on the population level, you're going to find more breast cancers when you expand the age range, and maybe you'll reduce some breast cancer death. But what becomes even more important as you get older is, do you affect mortality at all? And again, we're using that same modeling data, and we're not showing any effect on overall mortality, because as you get older, there's so many things that can get us. So maybe you avoid a breast cancer death only to die of heart disease at the same time. So I don't think there's any real new data. I think the time is right. And even in the guidelines, or even in the evidence review, they're calling for more data. And I think it would be ideal to do a randomized control trial on the oldest women where we really have no data of benefit, but it would need a lot of women who'd be willing to be randomized. And that's always been the challenge. But I think there's been, I've been doing this for 20 years and the data hasn't changed. And there's no data that helps people live longer or better, particularly in that age group. And it would be lovely to actually have some data to help inform these decisions.
There's a question in the chat. Is having a mammogram yearly recommended if you have no history or problems? Do you need to have one? So I guess for those people who are, healthy or the other end of the spectrum and competing mortalities.
Yeah, so I mean, the USPSTF, even in the new guidelines, stick with being screened every other year and don't go to every year. And the American Cancer Society for women 55 and older recommend every other year and not every year. And those are usually some of the more, I don't know if evidence-based, they try to take account the harms and the benefits, whereas some groups like the American College of Radiology ignore any harms because they are looking for only breast cancer benefit. So they tend to be more aggressive and they say every year. But the reason is a lot of the data suggests, so there are like this barnyard analogy to breast cancer. There's ones that are birds that no matter what you do, they're going to go out and they're going to get you. We can't do anything. Maybe treatment will help. And there's some that are turtles that are so slow, and that actually a mammogram, they're so slow they would probably never kill you. And there's some that are rabbits that maybe we can get in a fence. Anyway, there's this analogy that so mammograms might help us catch the rabbits. But in general, whether you do a mammogram once every year or every other year, you're still going to check, you're going to have a chance of catching those ones that are fast enough to make a difference in your life, but not so fast that the mammogram doesn't catch them anyway. Like they're so fast, they're the ones that mammograms aren't going to help you with. They can't help you. They're just too fast. Nothing we can do is going to probably reduce the chance of dying from those breast cancers. So usually going once a year or every other year does not make a difference in overall outcomes. There's some data that maybe there's a little bit of stage shift, but in the recent evidence review, most of the studies aren't finding a big change. So for those women 75 and older, if you're going to get screened, unless you've had atypical hyperplasia or some extreme risk factor, I would say every other year is more than enough. And again, I don't think there's data to even support screening.
Alad, you had a comment?
Yeah. I wanted to say, I think that I agree with everything that's been said about the recommendation for screening every other year is the one that has the most evidence behind it. The Preventive Services Task Force, in one of their statements about where more research is needed, they did state that more research is needed about where annual versus every other year is better, and that is essentially one of the things that we are testing in Wisdom. So there's one arm of the trial, as many of you know, is we're recommending every year, and then the other arm of the trial where most women are getting every other year, except for some high-risk women who are identified by some combination of risk factors. And so we are hoping to at least answer whether there's equivalence between those two possibilities, which may, hopefully with some future guidelines, be able to be incorporated for recommendations.
Yeah. And I think too, just we are talking still just based on age, and there are other risk factors as we've discussed too. So if you are high risk, if you have a strong family history, genetic risk, screening more frequently might be recommended, but it's a matter of understanding all of those comprehensive risk factors. There was another question, if you could comment on every year or every other year screening for women with dense breasts. So again, one of the other risk factors that we think about, and if there's any other diagnostics or tools for dense breasts on the horizon.
Yeah, so the USPSTF did, they reviewed all the studies in this area, and they did not find convincing evidence that any supplemental screening with MRI or ultrasound improved outcomes. And in terms of digital breast tomosynthesis, there's we generally, 5 to 10 years ago, everyone was getting digital mammography, and now 78% of centers have what we call 3D mammography. 3D mammography was associated with higher radiation because it was being done with what we call digital mammography and 3D mammography, but nowadays they're kind of doing 3D mammography alone, and radiation is maybe a touch higher than just the regular digital mammogram. And that was thought to be better for dense breasts, but more and more data is suggesting it's pretty similar to digital mammography. So, and then if anything, sometimes there's more uptake of radiation in dense breasts. So I think the jury is still out.
Okay. I know there are other studies going on looking at abbreviated MRI and fast mammograms and things like that, but none of that is offered right now as a standard. There are some trials across the country that are going on. I know our site at University of Chicago is running one of those such studies for abbreviated MRI. And that's just for women at high risk, not necessarily just with dense breasts, but high risk for other risk factors as well.
And also breast density changes over time. So as women age, their breasts become less dense. So it's still important. There's about, I think 25 to a third of older women will have dense breasts, but it's at middle age, it's more like half and half. So in some ways, regular mammograms are a better test as you get older because your breast tissue is less dense, and regular mammograms are easier to read when the breast tissue is less dense.
Great. All right, other questions? Okay, and just to sort of circle back, I think, as I mentioned before, there are so many risk factors that we know about. We know that breast cancer grows at different rates. If there is a breast cancer, one thing in the future that we're trying to do in the Wisdom study is trying to do an assessment to see who's at risk for which types of breast cancer, some of those more aggressive breast cancers, or those that are estrogen receptor negative breast cancer. So there's a lot more work that we in Wisdom are hoping to do in sort of our next version, and really try and refine our risk prediction and understand the safest risk or the safest screening buckets for everyone on an individual level. So just to wrap up too, there is a poll that looks like it's been launched. If you have a minute just to fill that out real quick. And then just again, to wrap up, that we know that one size doesn't fit all. We are really looking forward to when we can start to report out our wisdom data so that we can inform these guidelines and help provide some clarity to the discussion and the debate about breast cancer screening. And, you know, our whole goal is really to identify women who are at risk for those more aggressive cancers where screening may not benefit them because their cancers will grow so quickly. And just to note as well that even if you have a normal mammogram, if you feel something, if your breasts change, if there are symptoms that come up, always go and ask for your doctor's advice and to get screening. Just because you had a normal mammogram a couple of months ago doesn't mean that you're in the clear for, you know, the next year. Those symptoms can pop up and they're important to get help. So please do make sure that if you have those symptoms, you can seek out some help from your physician. We have just some information about how to participate for those who aren't part of the study, or if you know someone who is interested in the study. We are just about to start our next version of the Wisdom study with upgraded risk models and a larger genetic set of genetic information that we'll be gathering. Towards the end of the year, we're hoping to expand to women in their 30s, offering a genetic test and risk assessment to women in their 30s. So lots of exciting activity going on in the Wisdom study. Women can still go to our website and register, and we'll make sure that we reach out to you when we're ready to have you join that next phase of the study. And just again, for other ways that you want to get involved, there's lots of opportunities that we have, and we'd love to hear from you if there are ways that you want to help us share the Wisdom study across your networks and your communities. This is one way to bring people together to talk about breast cancer screening, breast health, and women's health. And there's lots of other opportunities to get involved as well. So with that, yeah, our next community forum, forgot to update that, will be in June, the last Monday of June. And just want to say again, thank you to everyone for being part of this community, for helping us to learn what matters most to the community, but also to work together to help to generate new data and new evidence to support additional guidelines and refinements to those guidelines where we can help improve outcomes for all women. All right. Well, thanks everyone so much. I hope you have a wonderful end of your day and wonderful evening, and we'll look forward to seeing you in June. Thanks so much.
Thank you.